Vanakkam. Congenital differences are always a challenge to the reconstructive surgeon. The two main basic aims being reconstruction to provide a functioning hand and reconstruction to provide a hand that is cosmetically acceptable. In this session, we shall see a very common problem, congenital syndactyly, that is fusion of fingers. What are the features in congenital syndactyly? What type does it belong to? Should we operate or not? And if we should operate, what surgery should we do? All these and more in this video. We shall see the presentation, examination, investigations to be done, and decision making, and the decision making for a patient with congenital syndactyly. At the same time, we shall discuss all the questions and answers about congenital syndactyly. This was a 4-year-old female child who presented with fused fingers since birth on both hands. This child was born of non-consanguineous parents and was the third child of 3 children. There are no syndactyly among the siblings. This child does not have syndactyly in the toes. The father of the child has a syndactyly between the middle and ring fingers on both his hands and has not had any treatment for the condition. So just by looking at the hands, we can make a diagnosis of congenital syndactyly. But there is more to it, and we shall see all the details. What is the meaning of the term syndactyly? Syndactyly is a word derived from Greek, where syn means together and dactylos refers to digit, which could be finger or toe. What is the incidence of congenital syndactyly? It is placed at around 1 in 2000 live births. So this makes it a very commonly encountered congenital difference. Now we are dealing with a patient with bilateral congenital syndactyly. What is the incidence of this condition being bilateral? The incidence of bilateral congenital syndactyly is more than 50%. What is the male-female ratio of incidence? It occurs twice as common in males than in females. Is it genetically inherited? Yes, 30% of congenital syndactyly is inherited. And how is it inherited? It is transmitted in an autosomal dominant pattern with variable expressivity and incomplete penetrance. It has been identified on chromosome 2, and mutations have also been seen in the HOXD13 gene, which is also on chromosome number 2. Which are the commonly affected fingers in isolated syndactyly? More than 50% of the cases of isolated syndactyly present as syndactyly between the middle and ring fingers. There is a very easy mnemonic to remember the incidence of syndactyly between the fingers. You can remember 5, 15, 50 and 30. This denotes the percentage of occurrence of syndactyly between the fingers from the radial side to the ulnar side. That is 5, 15, 50 and 30. How does syndactyly occur? Syndactyly results from a failure of differentiation. That is, there is a failure of the digits to complete the normal process of separation. So what is this normal process by which the finger and finger webs are formed? The hand segment forms a paddle called the hand plate at around the 5th week of gestation. At around 48 days, 4 ridges develop in this hand plate. From these ridges, the process of apoptosis, that is, programmed cell death begins, and this is mediated by the apical ectodermal ridge, and this proceeds in a distal to proximal fashion. So by this process, we can understand that the finger webs are the last to form, and this is completed around 51 days of gestation. The first to separate is the thumb index finger. After the separation, the digits undergo segmentation and the development of touch pads, which occurs at around 56 days of gestation. What is the pathological anatomy of syndactyly? There are four important points to remember. First, the skin and subcutaneous tissues are normal. Second, there are tight facial bands between the fingers and there is an abnormal thickening of the palmar fascia like the Cleland's ligament and the Grayson's ligaments. Thirdly, there may be an anomalous sharing of the musculotendinous units, nerves and vessels between the fused digits. And finally, the growth will be affected. That is, there will be a progressive angular deformity of the longer finger that is involved. As in this patient, where the middle ring and little fingers have been involved, the middle finger and the ring finger have restricted growth, which can be seen by the angulation in the fingers, both on the sagittal axis and the coronal axis. So this child has a fusion between the middle, ring and little fingers involving both hands, and there is an angular deformity in the middle and ring fingers. The nails are fused with the ridge present between the adjacent nails. This suggests that the bones, that is the terminal phalanges of the three fingers, may be fused also. You will also note that the creases are well developed at the PIP joint on the volar aspect, but there are only faint creases at the metacarpophalangeal joint and the distal interphalangeal joints. This suggests some restriction of movement at these joints, but the active range of movement is full at the MCP joint and the PIP joint, but there is a restriction of movements at the distal interphalangeal joint. Now that we have seen a child with a congenital syndactyly, how do we classify it? Syndactyly can be classified based on the anatomy, pattern of presentation and the genetic pattern. What is the anatomical classification? It is simple versus complex versus complicated, and it could also be complete versus incomplete. Let us first consider the simple versus complex versus complicated syndactyly. Simple syndactyly indicates only fusion of the fingers, but there is no fusion between the bones in the fingers. Complex syndactyly indicates that there is a fusion of the bones, usually the terminal phalanges, which are fused, and complicated syndactyly refers to those syndactylys in which there are extra bones and the tendons and muscles have also developed abnormally. When we consider the complete versus incomplete syndactyly, complete syndactyly refers to fusion of the fingers till the tips, as seen in this patient, and incomplete syndactyly refers to partial fusion of the fingers not extending up to the tips of the fingers, as seen in this example. So what is the anatomical classification of the patient under consideration? It is most probably complex because the nails have been fused together, which means that the terminal phalanges could also be fused, which of course we need to confirm with an X-ray, and it is complete because it is involving up to the tips of the fingers. Now what is this classification system based on the pattern of presentation? There are three types. The first is isolated syndactyly, and this is known as non-syndromic syndactyly. The second type is where it can be associated with upper limb musculoskeletal disorders, and the third type is where syndactyly is associated with other syndromes, and this is known as syndromic syndactyly. Let us first see what is non-syndromic syndactyly. Here syndactyly alone is present. It may involve the hands and feet, and this is usually inherited. How many types of non-syndromic syndactyly are there? Temtame and McKusick in 1978 classified non-syndromic syndactyly into 5 types, but this was modified later by Malik et al. Into 9 types of non-syndromic syndactyly. Let us see what these 9 types are. Type 1 or SD1 is the most common. This is further subdivided into 4 subtypes. Subtype 1A or zygodactyly being the most common. Syndactyly type 2 or SD2 involves syn polydactyly, which is further divided into three types. Syndactyly types 3 to 7 have their own names and own phenotypic presentations. Syndactyly type 8 is divided into two types, while syndactyly type 9 is known as the Malik-Person type. So far, we have seen the 9 types of non-syndromic syndactyly. What are the upper limb musculoskeletal disorders that could be associated with syndactyly? Sometimes syndactyly is not isolated, it may be associated with some other disorders. For instance, like cleft hand. Here there is a syndactyly between the thumb and the index finger along with the cleft hand. There could be an ulnar side limb deficiency as seen in this example, or there could be a symbrachydactyly or a synpolydactyly. Now we shall discuss another important type of syndactyly, that is the syndromic syndactyly. So what are the syndromes that could be associated with syndactyly? There are 6 main syndrome complexes that could be associated with syndactyly: Poland syndrome, constriction ring syndrome, acrocephalosyndactyly syndromes, acrocephalopolysydactyly syndromes, orofaciodigital syndromes, and oculodentodigital syndromes. Let us now see the main features of these syndromes so that we can recognize them or look for them when we come across these conditions. Poland syndrome is associated with aplasia of the chest wall muscles, which is unilateral, and symbrachydactyly of the hand, which occurs on the same side as the aplasia of the chest wall muscles. This shows the typical pattern of syndactyly that occurs in Poland syndrome, where there is a shortening of the fingers due to absence of the middle phalanx of the fingers, hence known as symbrachydactyly. When we consider the constriction ring syndrome and the syndactyly that occurs in this condition, there are 4 categories as described by Patterson. The first is simple constriction rings, the second is constriction ring with deformity of the distal part like lymphedema, the third is constriction ring with distal fusion of the fingers called acrosyndactyly, and fourthly amputation of the fingers. That is type 1 with simple constriction rings, type 2 constriction ring with deformity of the distal part, which is usually lymphedema, type 3 constriction ring with distal fusion of the fingers called acrosyndactyly. Here we should note that even though the distal portion of the fingers are fused, there will be a sinus tract representing the finger web that had been formed normally, and type 4 where there is amputation of the distal portion of the finger. In this example, you can see the constriction ring, the distal lymphedema, the amputation that has occurred, and the acrosyndactyly that has occurred, that is fusion of the distal portions of the finger. The third type of syndromes associated with syndactyly are the acrocephalosyndactyly syndromes, and there are 5 basic types of these syndromes. They are the Eppert syndrome, the Cruzon syndrome, the Sétre-Shorten syndrome, the Goodman syndrome, and the Pfeiffer syndrome. Of these, the 2 most important are the Eppert syndrome and the Sétre-Shorten syndrome, and we shall see their main features. Eppert syndrome is characterized by widely spaced eyes or hypertelorism, bulging eyes, and downslanting palpebral fissures, maxillary hypoplasia, palate abnormalities like cleft palate may be present, and syndactyly between fingers. We shall now see the characteristic features of the syndactyly that occurs in Eppert syndrome. There are 3 types of syndactyly here. The first type where the thumb is free, but between digits 2 to 5 there is a complex syndactyly with fusion of the terminal phalanges. In type 2, there is a simple syndactyly involving the thumb, but there is a complex syndactyly involving the other digits. and in type 3 there is a complex syndactyly involving the thumb also along with the other digits. In the Sétre-Shorten syndrome, there is an asymmetrical head and face due to craniosynostosis and ocular hypertelorism with shallow eye cavities. Cutaneous syndactyly of the fingers and toes are noted, and the intelligence is usually normal in these patients. The fourth type of syndrome complex associated with syndactyly are the acrocephalopolyssyndactyly syndromes, and there are 5 basic types here: the Noack, the Carpenter, the Sakati, the Goodman and the Pfeiffer syndrome. Of these we shall consider the Noack syndrome and the Carpenter syndrome so that we do not miss these conditions when we see them. The Noack syndrome, which has been identified as a type of Pfeiffer syndrome, is associated with craniosynostosis, conductive hearing loss and polydactyly involving mainly the thumbs and the big toes. In Carpenter syndrome, along with syndactyly and polydactyly, craniosynostosis associated with acrocephaly or brachycephaly, short stature, congenital heart defects, umbilical hernias and undescended testis may be seen. As the name suggests, orofaciodigital syndromes involve the oral cavity, the face, the syndactyly of the fingers and toes, cleft lip and lobe-shaped tongue, and there have been around 14 types of OFD, that is orofaciodigital syndromes, identified. The oculodentodigital syndromes involve, along with the syndactyly of the ring and little fingers usually, abnormal cornea, slender nose with narrowing of the nostrils, and defective enamel of the teeth and dry hair. Before we proceed further, we need to explain a few terms that we would come across when dealing with congenital problems in the hand, especially syndactyly. The terms brachysyndactyly, symphalangism and superdigit. Brachysyndactyly refers to associated shortening of the syndactylized digits. This is usually associated with Poland syndrome, and we have already seen an example of this. Symphalangism refers to congenital stiffness of the interphalangeal joints, commonly the proximal interphalangeal joint. So, the phalanges are also fused together. Hence, there will be no movement at the interphalangeal joints of these syndactylized fingers. And finally, the superdigit, where there is an abnormal ratio of metacarpals to fingers. There are 2 types here. The type 1, where 2 metacarpals support a single digit, and type 2, where a single metacarpal supports 2 digits. Coming back to our case, X-rays revealed fusion of the distal portion of the terminal phalanges, confirming that it is a complex type of syndactyly. So now we need to take a decision regarding the management of the condition for this child. And there are 4 main components of the decision making. Should we operate or not for this child? If we do operate, which hand to be operated first? Which fingers to be operated first, because 3 fingers are involved? And finally, what technique is to be used? Regarding whether we should operate or not, this child must be operated on because the creases are not well developed. So we need to get back movements. Secondly, the growth of the longer fingers has been affected and we can make out the angulation in the middle and ring fingers, and the surgical release would allow the fingers to grow to their normal potential. And thirdly, the cosmetic reason, which of course is optional, but this child has come to us mainly for this problem. We should also rule out any of the known contraindications to surgery for syndactyly, like for instance any condition that precludes elective surgery or anesthesia, severely diminished mental capacity, lack of concern with syndactyly, lack of individual stable skeletal elements for each digit, a superdigit, or even vascular insufficiency of any of the digits. Since none of these criteria are present in the case under consideration, we can plan for a surgical release. Having decided to operate, we need to take a decision now on which hand to operate first. This is a 4-year-old child, still partially dependent for all her needs on her parents, and they come from a poor socioeconomic status and a far off place and cannot come for repeated surgeries. We can plan for surgery on both hands at the same time. And having decided to operate on both hands together, we need to decide on which fingers to be released first. Here, the middle, ring and little fingers are involved. We cannot do the mid ring and ring little finger release together because it may lead to a vascular compromise of the ring finger. Hence, we need to do the marginal fingers release first. Here, on one side we have the middle finger along with the ring finger. On the other side we have the ring and little fingers. To allow the middle finger to continue its growth potential, we can plan to release the middle and ring fingers first. And the technique we shall be using will be the flat technique, that is a dorsal rectangular flap with a reverse T-shaped incision on the palmar side and interdigitating zigzag flaps to separate the finger and a full thickness skin graft to resurface the residual raw areas. So finally, we have made the decision to perform a syndactyly release. But we also need to know the different techniques that can be used, the pre-surgical counseling to be given to the parents of the child, the planning and the markings to be made, the actual surgical procedure as such, the follow-up that is required, and the results of the surgery in this particular patient. All these will be dealt with in the next video session. I hope you enjoyed the video. I enjoyed making it. Please click on the shown links to see more about other clinical conditions. And do not forget to subscribe to stay connected with the latest in learning hand surgery. Vanakkam.